Welcome to tonight's webinar series, Expand Your Digital Knowledge with the iTero Element. It is the third course in a three-part series titled iTero Element, Advancing Your Knowledge Base. It is being presented by Kelly Bevington, RDA, EFDA, and we will begin the webinar shortly. And with that, it is my pleasure to introduce Kelly Bevington, RDA, EFDA. She is the Director of Intraoral Technology here at National Dentex. She began her career more than 20 years ago as an RDA EFDA, graduating from Bryman College. Kelly has comprehensive knowledge of dentistry and the dental laboratory industry. She has been professionally trained on most major devices, and Kelly is able to provide expert chairside coaching. She manages the NDX clinical iOS training team and has clinically trained over 1,000 dentists and their teams. She enjoys sharing her knowledge by presenting webinars and is a regular contributor to dental publications. And with that, it is my pleasure to say, take it away, Kelly.
Thanks so much, Jessica. Appreciate that. Full disclosure, I am an employee of National Dentex. So iTero Element, advancing your knowledge base. We are a team of intraoral scanner trainers here at NDX. Myself, I'm in RDA EFTA. I manage the team, but I cover the East Coast as well. Brenda Kirkin is a CDA RDA, and she covers the Midwest. And then Brittany Carey is an RDH, and she covers the West. So we're going to review a little bit about best practices that we discussed in our previous two sessions. One is scan path protocol. Two is leaving the guidance tips on, especially for new users. Three is scan the prep or the scan body in the prep segment only, and always capture your interproximal contacts in the arch segment. So scan path protocol. It amazes me every time I go into an office and they claim to be, users of iTero, and they start like on the buccal surface. It's like, whoa, wait a minute, what are we doing? So it's strongly recommended from Align Technologies to utilize the scan path protocol of occlusal, lingually, then buccally for best speed and efficiency. Guidance tips. So the guidance tips you can find from your the gear, right? And then the scan setting, and it is leaving the guidance tips on. And what the guidance tips do is it gives you a little visual. So just, some photographs and 3 bullet points about what it is you're going to be scanning at that particular section. Super, super helpful, especially for new users. Tips about scanning the prep itself. We're always going to start on the occlusal, and we're never going to spend more than 8 to 10 seconds of time scanning the prep itself. And at the conclusion of scanning the prep, you want to make sure that this green dot here in the center is centered in the occlusal surface of the prep. I know we're talking about implants and we're talking about bites, but I would be remiss if I did not share this image that was provided to me by Align Technologies. Absolutely love it. So this would be appropriate for any type of preparation, whether it's a crown, a bridge, an implant, a veneer. It's what happens so quickly with the gingival tissue and how it can collapse and moisture begins to rise from the sulcus. So the image to our left, really nice and clear, and this is at 5 seconds. And by the time 13 seconds hits, woo, look at all the hemorrhaging, right? Lots of moisture there. So we want to avoid that. We want to scan quickly, and we want the area to be free and clear of any debris, hemorrhaging, saliva. It's not ultrasound technology yet. So today's agenda, what we're going to talk about today is tips for evaluating and confirming an accurate bite registration. I'm beginning with a PowerPoint presentation, and then I have an iTero scanner here and a Typodont that I will demonstrate some of this information as well. So we're going to review accurate bite registrations, rescanning for an incorrect bite, How to use the dye separation tool, super, super important, especially when you have multiple units involved. And then scanning an implant scan body. And we're going to spend some time on implant protocols. So bite registrations, and these are taken again from iTero and from the iTero scanner. So it's really important that when you're taking the bite registration, that you're taking it in the premolar area, right? I highly recommend to sit the patient up in a like a 90-degree angle. I think it's a bit unrealistic and perhaps unfair to the patient to have them completely reclined. They've been anesthetized and numb for a good period of time after preparation, during preparation, and then we ask them to close normally. And they're like, what do you mean close normally? I'm upside down. So let's sit them up. Ideally, I would take the bite registration before preparation, right? You could do a pre-treatment scan, the opposing scan, and then your bite registration, either before the patient has ever been anesthetized or shortly thereafter when they're still pretty comfortable. So premolar area, instead of completely back to the second molars, just much, much more comfortable for the patient. And we're going to start where the teeth interdigitate. I like to go up to the maxilla, capturing 2 to 4 millimeters of soft tissue, then down to the mandible, collecting 2 to 4 millimeters of soft tissue, and then pull the wand out. You will see the model begin to merge together at that point, looking something like this as the patient is in centric occlusion. If for some reason you see on the screen the patient open a little bit, that's not acceptable. You can easily press on the screen, wait for the delete segment to appear, select delete segment, and start again. Highly recommend that. So the analyzing tool, that's the prep separation tool. Again, it's to allow you to create your digital dye. It's not creating it, but it's you confirming that the digital dye is accurate, whether that be a prep tooth or an implant scan body. And I will show you live how to manipulate that image to correct it if it didn't auto-populate accurately. Another example, the dye separation tool. And the objective is that, make sure my annotate is on, is that you can see the prep, right? 360 degrees. Yep. Sorry, I was just checking the chat. Come on. I have to take it off and annotate. Bear with me a moment. Great. Okay, so we have covered in our previous sessions fixed crowns, bridges, and veneers. In future sessions, we're going to cover partials and dentures, and we can get into different full arch scans for surgical guides, bite splints, sleep appliances, and so forth in the future or on a one-on-one. But today we're going to talk specifically about implants. So a single tooth implant. Let me see if I can get this annotate to work again here. Okay, so we have the implant that's in the bone, right? We've got our custom abutment and then the crown that is going to go over top. Sorry, my annotation is not going to work and allow me to move the slide forward. So I'm not going to use the annotation. So there's 2 different types of implant crowns that the laboratory can fabricate, really 3, but there are cement retained crowns, then there are screw retained crowns, and there's screw cementable crowns. The screw retained crown seems to be what's most popular right now. It has sort of gone through flux over the years. So it used to be screw retained, then cement retained became more popular, and now it's back to screw retained. And typically that's occurring because of potential periodontal concerns that could happen if cement is lodged in the gingival tissue unknowingly to the dentist. So if you stay with cement, then, or I'm sorry, if you stay with screw, then the cement does not become an issue for you. So I really like this slide. It shows, lots of different ways that we have impressed for implants over the years with lots of different trays, right? Open trays, closed trays, lots of chairside time with the impression copings and trays to make certain that everything is picked up accurately for those implant crowns. So we're going from analog into digital. And when we shift to the digital, it's really comprehensive as far as the materials we can incorporate into those scans, such as CT scans. So lots of availability with different types of implants and different types of scan bodies. So this is just a variety of manufacturers that are here. Today, we're going to talk specifically about scanning with iTero, a scan body to create a custom abutment and crown. So an example of what different scan bodies look like, right? They are not all the same. They are all very, very different, but they all have some sort of a key identifier to them. And that could be a notch, it could be a bevel, it could be a number. And whatever that key identifier is, it's recommended to place it buccally when at all possible, because we really want to make sure that we get a good image of it. And typically it's easier for us as clinicians to capture that buccal surface. Now, if you have multiple units, you're going to actually alternate them. So you'll go from buccal to lingual, buccal to lingual. And the reason, if they're all the same type of scan body, and the reason for that is we have found over the years that if you don't, the scanner, although very smart, does not seem to be quite smart enough to identify that it's a different part. So it just sees, consecutive parts in a row. And when it's the same part, it doesn't want to pick it up. It thinks you're still back on the first scan body that you scanned. Excuse me. I've got a question real quick. Could you run through when we would use the pre-treatment scan? Yes. And the difference between the first and second scan? Absolutely. Was doing a scan for a crown prep and deleted the partial segment after processing. Okay, yes, I will address that live. And if you have a further question to that, please let me know. So again, talking about scan bodies. So here's another image of a scan body here, right? And that happens to be made by 3Shape. So every implant manufacturing company today, it's a pretty broad statement, but I would say at least 97% of implant manufacturers today have their own scan body. And we refer to using the manufacturer scan body of what the implant is in the bone as OEM, original equipment manufacturing. If you don't use OEM, that's fine. That's an option too. There are many available. This happens to be 3Shape. So 3Shape would not be OEM. There is Preet, there's Argan. They are compatible to a multitude of different implants that are in the bone, and know that that is also an option. When you're preparing your RX, your prescription for the laboratory, what's critically important for you to tell us is who the implant manufacturer is. What type of scan body did you use? Did you use an OEM? You know, if it's a Nobel implant, did you use a Nobel scan body? What the platform size is, what custom abutment material you want, and then what crown material you want. And if you want insertion to be cement or screw retained of that crown. Got another question. Same one. Okay. Pre-ordering the scan body can happen through the laboratory. So you can contact the lab and pre-order a scan body through us, or you can pre-order the scan body from the manufacturing company. Please know that every scan body is slightly different as far as how long it might take you to receive it, how many autoclave cycles it is good for. They are typically reusable, but there are specific instructions as to how many autoclave cycles it can go through before you risk it warping, so, or distorting in some way. So it's very important to keep track of how many times you have autoclaved that particular scan body. And you could keep track of that, you know, on autoclave bags as well. Your assistants could. So full arch scans are highly recommended for implant cases, especially if it's more than a single tooth, right? And I really try to explain why taking a radiograph of the scan body in place is super important. We really want to make sure that that scan body is seated properly and accurately before moving on with the scan. And the way to check that is through an X-ray. Now, the material that scan bodies have been manufactured from, fabricated from, is changing, has changed over the last 5 years. It used to be more of a plastic polypropylene type of material, which did not show up on radiographs. So they are making the scan bodies in a radiopaque material now versus radiolucent. And some of them are now having a metal collar, a metal band against the gingival tissue. So you're able to see it better in the actual X-ray. And then please note that when available, take advantage of selecting the pre-treatment scan. So with iTero, there is a pre-treatment scan option. And what the pre-treatment scan would be utilized for is specifically to capture the gingival tissue. So you're going to remove your healing abutment or healing cap and immediately scan the gingival tissue and those adjacent teeth in that scan. And the purpose for that, that's going to be like your gingival tissue mask, right? That you would receive in a model form. You will receive, you will see that in a digital form. The lab will have that digitally to be able to design and create a beautiful emergence profile for your final restoration. Super, super important. Take advantage of the pre-treatment scan and scan the tissue without the healing cap in place. When it's time to take the bite registration, please make sure that the scan body is removed and that healing cap or healing abutment is placed back. I would say 99% of the time, the patient is not able to occlude with the scan body in place. Here's a couple examples of some x-rays of the scan bodies, which I thought turned out really, really well. You can see that they are fully seated. Right? like you're looking here. And you're showing here. Thanks to my lab partners for that, right? I did want to mention ENCODE. So ENCODE is the easiest thing out there to scan because the ENCODE healing cap or healing abutment is the scan body. There's no need for removable, and you're just scanning the ENCODE itself. This is a new one. It's called the Emergence ENCODE. It has a pink matte finish to it to make it a little bit easier for scanning. And it makes it a little more aesthetically pleasing for the patient when they're in the process of healing, right? So it doesn't show up, you know, bright and reflective like a metal healing abutment would. And the ENCODE, when you're scanning it, the key identifiers or notches, right, is what's decoding exactly what the shape and size and so forth of that particular scan body. I just think it's really, really super awesome. This was provided to me from a lab when I was explaining to them the presentation for tonight. Oh, I lost my arrows. Okay, so my arrows aren't there. Let me go back to my annotation for a moment. So if you look at number 9, can you see the difference here? How much deeper it's inserted than on this image, right? So this was the first scan that the lab received, and we ended up having to remake number 9. Number 9 was determined that it was not fully inserted. It was not fully seated when that original scan was taken. So that's a really good example as to why it's important to do that. Oh, there's my arrows. Any questions about that? I know I get a lot of telephone calls about scan bodies and why is it important to take an x-ray of it. And I know I've done presentations in the past, and I've called very good clinicians, very good customers of ours, asking them for an example of a radiograph that I could use. And I was saddened to know that that wasn't part of their protocol. It is now that they understand the importance of it, but it's all about education, right? And us sharing best practices. This is an example of a scan body in place, right? But it was not taken out for the bite registration. And so this was the initial image that was captured. I just wanted you to have a visual as to what that might look like. Astra EV. Dr. Ramos, I am not familiar with Astra EV specifically. That EV is hard to seat. So that I'm going to leave that open in our chat and come back to it. And I will do some investigation and see if there's any helpful tips from AstraTech as to, you know, what could be done to make that an easier process for you. So when we're on the RX itself, you want to make sure that you are selecting the pre-treatment scan and that you're selecting the tooth number that you're going to be working on. And that pre-treatment scan, you know, it's a tiny little box there, like right above the apex of number 3. So really pay attention to that you're selecting it now, because once you come off the RX page and start to scan, you cannot go backwards to it. And I know that because I've learned the hard way. So the RX is pretty intuitive, right? And it's going to ask you about what type of restoration you're doing and what type of scan body and what type of implant abutment you want. And then it's going to shift to the implant manufacturer, as well as the crown material that you want. So scan body, implant manufacturer, there's a drop-down menu, and iTero is great about continuing to add new companies or companies that have been consolidated and adding their most accurate name. So they're kudos to them for that. It's difficult to keep up with. Next would be the actual implant manufacturer. And then what type of connection you have for the implant that you are requesting. So once the implant is fully identified by the implant manufacturer, the size, the scan body that you're using, then you're going to shift to the custom abutment and material that you want for the custom abutment. And then lastly is going to be the crown, what type of crown material you want for that. And then once the prescription is complete and you can continue to add information into the notes, the next process will be to actually scan. Now, somebody was asking earlier about the pre-treatment scan. So the pre-treatment scan is always your first scan, and it is green in the background versus blue. So when you're scanning your operative scan, that will be blue. Pre-treatment is green. And that's, so the pre-treatment is always going to be pre-treatment for implants. And it's going to be the gingival tissue, right? In some cases, you could use pre-treatment really as post-treatment. And we can go into that closer to the end of the presentation or in a future one, but that's more for like full arch roundhouse bridges that are going to be temporized as well. So it's a little different than what we're talking about tonight, but pre-treatment is green and operative scanning is going to be blue. So as I mentioned earlier, it's going to be scanning the area that the implant is in without the scan body in place, and that is your gingival tissue scan. Now, when it's time to do the actual implant scan body scan, you'll see that the background is now blue, right? And we are in scan number 2. And this is an example of the dye separation tool for the actual implant. I just wanted to throw that in there. Right. And then we have some images of the actual implant scan, like cleaned up, if you will. So the one on the bottom is the gingival tissue scan, right? And then the one on the top in monochrome is the one with the scan body in place. Question. So the question is pre-treatment only for the implant sulcus tissue or the scan arch as well? So you will capture the sulcus, the implant sulcus and tissue and adjacent teeth. Honestly, I do an entire scan, right? So my pre-treatment scan is going to be like my operative scan, except without the scan body in place. So I try to capture as much information as I can. How do you turn on or off the dye separation? I will show that to you during the demonstration portion. So those are done. Great. Once all of your scans are reviewed, you want to make sure that you're reviewing it after it's been post-processed and in monochrome before you shift to the envelope to actually transmit and send the case. This is a great question. Should the green dot be on the side of the scan body, or is it okay for it to be in the center of the whole of the scan body? So you do not want to put the green dot in the center of the whole of the scan body. And here's why. I have seen it disappear, right? It goes into the hole and I don't know where it goes. But the scan body itself disappears. So I do like to have it on the occlusal, but just outside of the hole, right? So it might be a little bit towards the buccal. Great question. So here's an example of what that pre-treatment scan looks like. And the scan bodies, right? And then this is an image to confirm just each, you can go to the encircled Bluetooth to hone in and really see each individual tooth prep, in this case, implant scan by itself. Okay, so this is how you can reach us afterwards. These will come directly to me, and then I can disperse them to either to keep it myself or to disperse it to one of the other team members to finish that. And this is us, our intraoral scanner training team. Super proud of the fact that we are all clinical individuals that really understand dentistry and understand the dental lab industry as well. Let me finish the chat before I go to the demonstration. Which scan, pre-treatment or scan body is the best to capture the adjacent contacts? So it's part of the operative scan is where you're going to capture the adjacent contacts, but not on the prep scan, right? It's the next segment. Okay, so I'm going to stop sharing the PowerPoint presentation. And I am going to start sharing the iTero screen. And I think everybody should be able to see my iTero scanner screen. Can you confirm that, Jessica?
Yes, we can.
Great, great, great. All right, so I'm gonna scooch out of the way a little bit. So notice on the screen with the new RX, you will see implant scanning and fixed restorations. I've seen lots of errors where people are selecting implant planning, and that is more for surgical guides. So we are still talking ultimately about a fixed restoration. So we're going to select fixed. I'm going to select pre-treatment. My implant is on number 30. And I'm going to select implant based at this time. From here, I can select right? Like a multitude of implants. Let's just pick Straumann, and then my scan body. My restoration type is going to be screw retained. And my crown is going to be full contour zirconia. So we are ready to roll. So we're ready to scan. Notice pre-treatment is selected. It is in the blue here at the top. And I'm going to go to the scan sleeve. So this pre-treatment is without the scan body in place. And while this is, warming up, so I've got the guidance tips on, my hand positioning is holding it underhanded, right? And I'm going to do occlusals, then lingual, and then buccal. And I'll do a quadrant. I want to make sure when I'm on the buccal that I'm capturing a good 2 to 4 millimeters of gingival tissue, because I will need that for my bite registration. Also, when I'm tagging back up on the incisals, I want to make sure that the dark line is removed, and that's confirming that the data from the lingual and the buccal has merged together. Okay, so that is my pre-treatment scan. I see there's a question here in the chat, so I'm going to grab it real quick. That is not a question. So let me get rid of that. Okay, so I'm always going to use the arrow to advance to the next section. And in doing that, it's now asking me for the opposing. So at this point, you could put the healing abutment back into place, or you could put the scan body back into place. You do not want to leave the tissue without something, because it will collapse, and it typically collapses pretty quickly. You'll see the guidance tips are on the screen, but it's no worries if you don't want to read it right then. It goes away as soon as you start scanning. So now I've got the occlusal, I've got the lingual or palatal, as well as the buccal. Again, when I'm capturing the buccal surfaces, I'm capturing a good 2 to 4 millimeters of gingival tissue, as I will need that for my bite registration. And as I'm coming back over the incisals, I want to make sure that that black line disappears. That is confirming that the lingual and buccal data has properly merged together. So now I am going to the bite registration. If my healing cap is in, it's perfectly fine to leave that in when I take the bite registration. I'm going to have the patient open. I'm going to insert the wand. I'm going to use my wand to retract their cheek. And I'm taking the bite in the premolar area. I'm starting where the teeth interdigitate. I'm going to go up to the maxilla, capturing 2 to 4 millimeters, down to the mandible, collecting 2 to 4 millimeters, and pulling the wand out. Sometimes the bite registration will turn purple while the wand is still in the patient's mouth. Other times it doesn't turn purple until you have fully taken the wand out. One of the questions I get asked frequently, and not necessarily specific to implants, but just in general, is what if I don't like that bite, right? Like, it's our responsibility as the dental professional to confirm what we see on the screen is indeed what the patient is presenting in the chair. So if for some reason this bite registration is not accurate, we can press and hold on the screen. A menu comes up. We can select, let's do that again. We can select the delete segment. It's the trash can with the X. It's always going to ask you, are you really sure you want to delete that scan? In this case, we're going to say okay, and we can take that bite registration again. Where the teeth interdigitate, up to the maxilla, down to the mandible, and pulling the wand out. And there we go. Okay, so next scan from here, I'm going to advance to the next scan with the arrow where it says bite. And so now it is just the implant scan body. Before I do that, I'm going to double check the chat in the QA here. I'm going to come back to that, Dr. Lupp, in regards to communications with the iTero scanner and identifying things. So sorry, I do not see the black line you're referring to. Yes, I can show that to you again. Question is it not necessary to capture the entire arch? For a single tooth, number 30, it's the only missing tooth on my Typodont patient. I would say a quadrant is fine. If it's real life and they have other missing dentition, or it's more than one unit, then I would absolutely want a full arch. And even with the quadrant, you want to make sure you go to the midline. I want to make sure that I'm getting that cuspid into place. Great. Okay, so scan body itself. And we're going to treat it like it is a prepared tooth. Okay, so the green crosshairs I am placing over the occlusal of the scan body. You can see the scan body is in place. And it's occlusal, then lingual, and then buccal. I'm going to try to get, a little bit more of the walls, both distally and mesially, and turn it off. So we talked about that green dot, right? I think having the green dot here on the buccal a little bit is just perfectly perfect. So now we will go to the next segment, and that is going to be the rest of that lower arch. Now, you can take the scan body out at this point if you need to capture the inner proximal contacts adjacent to the implant. Oh, and I'm going to see if I can duplicate what I was talking about earlier with the black line on those incisal edges. Okay, so as I wrap over to the incisal edge, can you see how it's black? And then as I continue to scan there, the black goes away, that shadow goes away. And that is confirming that the lingual and buccal data has now successfully merged together. Critically important for full arch scans, for bruxism appliances, right? Like super, super important. Invisalign, all those good things. So let's take a look. There's an opportunity for improvement here on the mesial of number 31. So I'm going to activate the fill tool. If you are not familiar with the fill tool is going to encircle in red any data that is missing, that I can go in and rescan just that area without risk of contaminating the rest of my good scan. So here's the fill tool, right? It's the mesial of 31 that I want to capture. And as I begin to capture it, you can see that it turns tooth colored, right? And we are good to go. So I'm going to post-process at this point. It may take a moment when on TeamViewer and sharing screens here. So I'm going to go to the chat while our little while our spinning hourglass is going. Okay, question. Are you saying to complete the scan body scan, you can remove the scan body to pick up the adjacent proximal? Would the scanner try and erase the scan body? In my experience, yes, you can remove the scan body. I don't want you to hover over top of the implant site though. I just want you to focus on that mesial or distal interproximal wall. Great. I hope that answered the question about the black line on the incisal edges. Here's one. It looks like there's some missing data at the base of the scan body. If there's, it's more of a percentage. So as long as you have a good, 85 to 90% of the scan body, specifically the occlusal surface where the access hole is, and whatever that key identifier is, whether it's a bevel, a notch, a ditch, there's all different types, then you should be in good shape there. Good. Okay, so we are post-processed. And dye separation tool. So let's do one thing, right? I always want to look at things in monochrome as well as color, specifically for real prep teeth, right? It's really important to see the crisp clarity of the margin and your finish line. Okay, so this is the prep for tooth number 30. And the dye separation tool would allow you to take the plus sign and you could actually get it more at an occlusal angle. Take the plus sign and you could add You see the red line? I'm adding some data here. Actually going to add even a little bit more so that the tissue is completely encircled in the digital dye. Now, oppositely, if you wanted to erase it, you could do the same thing, right? And I'm just going to over exaggerate here so that you can see what I'm doing. Right? See how that removes? Or you could add it back in place. And when you tap on the swirly arrow at the bottom, when it turns blue, you're able to move it around, right? And when you tap on it and it's gray, then it stays still again.
With that, any final remarks, Kelly? Looks like you're getting some great kudos, great presentation.
Yeah, no, just thank you. Just a big thank you. I'm honored to be afforded the opportunity to have a job that I really love what I do. So thank you for all of you for allowing me to do it. It means a lot.
Thank you, everybody. And as
right.
always, take care.
Take care. Have a good night.
Take care of those patients. And don't forget to fill out the survey to let us know how we can take care of you.